Good morning, and welcome to Curis Emavusertib update call. All participants will be in a listen-only mode. Should you need assistance, please signal a conference specialist by pressing the star key followed by 0. After the company's prepared remarks, all participants will have an opportunity to ask a question. To ask a question, you may press star then 1 on your touchtone phone. To withdraw your question, please press star then 2. Please note this event is being recorded. And I would now like to turn the conference over to Diantha Duvall, Curis' Chief Financial Officer. Diantha, please go ahead.
Thank you, and welcome to Curis' Emavusertib update call. Before we begin, I would like to encourage everyone to go to the investor section of our website at www.curis.com to find the Curis Announces Positive Emavusertib Update press release. I would also like to remind everyone that during our call, we will be making forward-looking statements, which are based on our current expectations and beliefs. These statements are subject to certain risks and uncertainties, and actual results may differ materially. For additional details, please see our SEC filings. Joining me on today's call are Jim Dentzer, President and Chief Executive Officer, Dr. Ahmed Hamdi, Chief Medical Officer, and Dr. Jonathan Zung, Chief Development Officer. We will also be available for a question and answer period at the end of the call. I'd now like to turn the call over to Jim.
Thank you, Diantha. Good morning, everyone, and welcome to Curis' Emavusertib update call. We're excited to report updated data from the Take-Aim lymphoma study in primary CNS lymphoma, one of the most rare and most difficult to treat of the NHL subtypes. As a reminder, the Take-Aim lymphoma study is a 3-part study of emavusertib in combination with ibrutinib in patients with relapsed refractory PCNSL. Part A, the dose escalation part of the study, is complete. Part B is the single-arm study in BTKI experienced patients. And Part C is the randomized study in BTKI naive patients. As you may recall, we reported data for patients treated in Parts A and B of the study last year with a May 1st, 2025 data cutoff. At that time, we reported a 71% overall response rate in BTKI naive patients, with 5 of 7 patients achieving a response. We're pleased to report that as of the July 1st, 2026 data cutoff, the ORR is now 86%, with 6 of 7 BTKI naive patients achieving a response. When we focus on evaluable patients, those patients who were able to complete at least one cycle of treatment, the response rate increases to 100%, or 5 of 5 BTKI naive patients. For context, it is important to note that published studies of BTK inhibitors in PCNSL have generally shown response rates of 40 to 70%. Clearly, the combination of emavusertib plus a BTK inhibitor appears to be better than BTKI alone. For BTK experienced patients, those patients whose disease has progressed while taking a BTK inhibitor, the results look arguably even more impressive. Last May, we reported a 27% response rate with 7 of 26 patients responding. A year later, we have increased the patient data set by 50%. We now have 39 patients, and the response rate has remained consistent with a 26% ORR and 10 of 39 patients responding. When we focus on evaluable patients, again, those patients who were able to complete at least one cycle of treatment, the response rate increases to 33%, or 10 of 30 BTKI experienced patients. For context on this population, patients who have failed both frontline therapy and BTKI have a very poor prognosis, with many patients proceeding directly to hospice or best supportive care. That emavusertib is helping patients change that story and reverse their disease is very encouraging. In short, The updated data in both BTKI naive and BTKI experienced patients continue to show strong activity and continue to support the potential for accelerated approval submissions in both the U.S. and Europe. As the study continues to advance with strong support from clinical investigators and key opinion leaders in the PCNSL community, we look forward to completing full enrollment in the registrational dataset on schedule in 2027. Now let's turn to CLL. As you recall, last year we engaged with a number of KOLs who were excited about expanding our emavusertib studies into additional NHL subtypes. They were especially interested in exploring emavusertib's potential to fundamentally change the treatment paradigm for CLL patients, where the current standard of care is BTK inhibitors. Over the last decade, BTK inhibitors have become standard of care in CLL and NHL because of their ability to block the BCR pathway and help patients achieve objective responses. However, these responses are typically partial responses, not complete remission. The result is that patients treated with a BTK inhibitor end up having to stay on it in chronic treatment for the rest of their lives. Additionally, because they never achieve complete remission, many of these patients develop BTKI-resistant mutations, and ultimately, their disease progresses. We are looking to improve upon the current standard of care by adding emavusertib to a patient's BTKI regimen, applying a dual blockade to the two biologic pathways driving CLL. This dual blockade, with BTKI blocking the BCR pathway and emavusertib blocking the TLR pathway, can enable patients whose NHL subtype partially responds to a BTK inhibitor to achieve deeper responses with the combination, including the ability to achieve complete remission or undetectable disease and the potential for time-limited treatment. If we are successful, adding emavusertib to BTKI could change the treatment paradigm in CLL, reducing the risk of developing a treatment-resistant mutation and improving a patient's overall quality of life. The first step in testing this hypothesis in CLL is our proof of concept study in patients currently on BTKI monotherapy who have achieved partial remission but have been unable to achieve complete remission or undetectable MRD. Enrollment in the CLL study continues to gain momentum. Just a few weeks ago, we announced that we had 11 clinical sites activated and that we had consented our first 6 patients. Since then, we have consented 4 more patients, bringing the total to 10 patients consented. With that strong momentum, we are pleased to reiterate our guidance that we expect to dose the first 5 patients by the end of this month, and we're raising our guidance for clinical data from 5 patients to 5 to 10 patients by year-end. It's been a terrific year so far, with updated PCNSL data reinforcing the regulatory strategy for our first NHL submission, and demand for CLL enrollment exceeding our expectations, reflecting both the clear unmet need in CLL and the support from the clinical community that emavusertib has the potential to address that need. We look forward to providing additional updates as the year progresses. With that, I'd like to open the call for questions. Operator?
Thank you. Ladies and gentlemen, we will now begin the question and answer session. Should you have a question, please press star followed by the 1 on your telephone keypad. You will hear a prompt that your hand has been raised, and should you wish to cancel your request, please press star followed by the 2. If you're using a speakerphone, please lift the handset before pressing any keys. One moment please for your first question. And your first question comes from the line of Kripa Devarakonda from Truist. Please go ahead.
Hey, guys. Thank you so much for taking my question, and congratulations on the progress. I was wondering if you can remind me what the specific number of BTKI-experienced patients required for the registrational data set is, and is there a floor ORR the FDA expects to see for this patient population? And I know I don't think you mentioned it, but just was wondering if you have any sense of median duration of response for these responders that you talked about today.
Yeah. Thank you, Kripa. Appreciate the questions, and thank you for joining. So just as a reminder, when we went back and had our discussions with FDA, one of the reasons we selected PCNSL in this salvage line setting is because the alternatives are so grim. So patients post-BTK, once they failed not just chemo and methotrexate in frontline, but then they've gone on a BTK inhibitor and their disease has progressed after that, they have no options. There's nothing approved. There is no consistent guideline. And many of those patients are frankly too frail to even take another round of chemo. So oftentimes these patients end up going to best supportive care or hospice. So the ORR in that population is really zero. Nobody publishes results for that population because nothing works. When we had the discussions with the regulatory authorities, what we said is, look, we all understand that the real world response rate is zero. Let's just suggest a statistical lower bound of 10%. And if we can get more than 10% responses, statistically, p-value less than 0.05, would that be sufficient? And then the answer from both the EMA and FDA says, yes, there's nothing for these patients. If you can show that you can exceed that lower bound, that would work. So now we had a discussion about the stats. And if we see a response rate of 20% or higher, in order to achieve a p-value of 0.05, we would need somewhere in the range of 45 to 60 patients. So then the question to EMA and FDA was, would that size of data set be sufficient, knowing that we need to address safety as well as efficacy? And our conversations were very successful. Both agencies thought that was reasonable, and so that's where we're headed. And that's why we expect to have that data set fully enrolled by next year. And then the follow-on question that you asked about duration was, well, what sort of duration do we expect to see? Well, in this population, as I said, nothing works. So any duration would be terrific. The largest study ever done in this population was the ILAC study by Curis in Paris. And that study, as a reminder, showed that progression-free survival in BTKI patients is 2 months. So we've shown so far that we can get to 4 to 6 months. In fact, some of our patients have been on drug now for over 2 years, approaching 3 years. I suspect we're going to have a very strong story to tell, assuming that the data hold between now and full enrollment. Our response rate and our duration are better than we were expecting. So thank you for those questions.
Thank you so much. Thank you. And your next question comes from the line of Yale Jen from Laidlaw & Company. Please go ahead.
Good morning, Jim, and congrats on the great data, and thanks for taking the questions. My first question is that given for the PCNSL that both patient BTK naive and the BTK experienced patients show very compelling data, would you also consider filing for the first line as well as for the second line? And what might be the additional work needed for potentially achieve both sides? Then I have a follow-up.
Yeah. So thank you, Yale, first and foremost for the questions and also for dialing in today. We appreciate it. Yeah, I mean, you raise a very exciting prospect. So we're looking at an oral combination of patients that in the evaluable population has a response rate of 100%. Now, those are patients that are second line. They've already been through chemo and methotrexate, right? Chemo and methotrexate is frontline therapy. But the published reports for chemo and methotrexate are that the response rate is 80. We're looking at a response rate in second line with an oral, so a far easier regimen to tolerate than frontline with chemo and methotrexate. Now, I'm not prepared to suggest that with our small data set, we only have 5 evaluable patients, 7 ITT, right? It's a very small data set. I don't know that I want to take that next step and say that we think we can leapfrog into frontline therapy in these patients. I think that's premature. But I would say we feel very confident that the drug is active. It's clearly adding efficacy to a BTKI regimen. And we think that the prospects for gaining our first label, first in the salvage line, and then with full approval in combination with BTKI, our overall thesis is there's a $12 billion market for patients with NHL who take a BTK inhibitor. Overview would be we're going to go into all 5 of those indications, PCNSL first, but then CLL, Waldenstrom's, mantle cell, marginal zone. Wherever a patient takes a BTKI inhibitor today, those patients tomorrow, with these data hold, suggest they should be taking BTKI plus EMA. And that's a really exciting place for us to be. So thank you for that.
Okay, great. Maybe just a follow-up. With this data at this moment, would you thinking of schedule a meeting with the FDA, or you will wait until, for example, end of the year to have the data, to have a meeting with FDA, maybe even accelerate the process further instead of waiting for the completion of the enrollment in next year for the salvage line. And at the time also in terms of the BTK naive, if you have more data there, again, the same question, whether you will have a conversation with the agency to discuss all the possibilities. And thanks.
Thank you. Again, a great question. So on the regulatory strategy, I'd say we've got a really good dialogue going with FDA. They greatly appreciate it. And we should remind everyone, when we went to the FDA, we brought with us 2 key opinion leaders, right? The head of primary CNS lymphoma for Sloan Kettering and the deputy chair of lymphoma for Mayo Clinic in Rochester. The support from the community, and then the support that we gained from FDA and the EMA was really encouraging. At this point, the dialogue is terrific. They're glad that companies like Curis are pioneering novel molecules in areas of clear unmet need, where patients really do need access to a therapy that can extend the quality of their life. And so far, the data seem to support that enthusiasm. I'd say right now, we plan, as the data come in, to reach out to the FDA and EMA where appropriate to take advantage of any opportunity we can for accelerated treatment or favorable regulatory action that could be beneficial to getting this drug to patients as fast as possible. So as I said, right now, we're continuing to look at a drug that is performing really well in its first indication, and the second one, CLL, the much larger indication. The enthusiasm from the community is really exciting for us, and I look forward to both better data as we move forward in CLL as well as PCNSL, but also an ongoing discussion with regulatory authorities. So I'd say stay tuned.
Okay, great. Okay, thanks a lot, and again, congrats.
Thank you very much. I appreciate it.
Thank you. And your next question comes from the line of Sarah Nick from H.C. Wainwright. Please go ahead.
Hey, good morning, and thanks for taking the question. Congrats on the progress. Happy to hear it. And just had one question regarding the PCNSL. If I heard correctly, the BTKI naive cohort enrollment has been, I think, still at 7 patients since the May 25 cut. I just wanted to understand if Part C is still actively enrolling, and if it's not, maybe if you can provide some color on any potential impediment. Is it just the competing frontline options, site prioritization, or something else? Thank you.
Yeah, no, so thank you, Sarah. So again, just as a reminder, We started enrolling in the early days in Part A, which was dose escalation. We enrolled patients as low as 50 milligrams all the way up to 400. And we did it in multiple indications, and we did monotherapy, we did combo, we did naive patients, we did experienced patients. So in those early days, we dosed several naive patients in PCNSL. And it's those patients that we continue to follow. And in fact, one of those patients who wasn't a responder last year in May has now become a responder. And in fact, we have another CR in that population, which is very encouraging. The next step strategically for us is to gain our approval. So once we had our dose and we were following those patients, we moved into relapsed refractory patients in the experienced setting, because those are the patients that are going to support what we hope is an accelerated approval. We know that once you get accelerated approval, you have to follow on with full approval. And that has to be a randomized study. It will be a BTK in one arm, BTK plus EMA in another arm. And we're going to need to be able to show as part of our submission that we've got a contribution of components, that in fact what appears to be true now, it continues to hold, that emavusertib plus BTKI is better than BTKI alone. So we've made really good progress on our approval data set. I expect the full approval data set is one that's, typically with most companies that comes several years later. So yes, we are getting started in that study and we're beginning to enroll patients. We need to have that study ongoing by the time we file for our BTKI experienced label. And we will. And as those data mature, we look forward to, obviously reporting out on those as well. But the lead and clearly the emphasis is on the registrational data set, which is the BTKI experienced patients. I hope that's helpful.
No, that's helpful. Thank you.
Thank you. And your next question comes from the line of Boris Beaker from Jones Trading. Please go ahead.
Great. Thanks for taking my questions. I'd like to add my congratulations on the progress. Maybe my first question on PCNSL. If we look at BTKI resistance, at least from what I could find on PCNSL, it's either typically with BTK C481S mutation or just a bypass of activation of MYD88 TLR pathway altogether, which obviously what IRAK4 targets. I'm just curious if you've sequenced the baseline tissue or liquid biopsy of these BTKI experienced patients to get a better understanding what their actual mutation was and how your drug kind of fits in within that mechanistic pathway.
Sure. Thank you, Boris. I appreciate the question and thanks for joining. I'm actually going to ask Ahmed Hamdi to chime in on that. Ahmed, if you wouldn't mind.
Yeah. Hi. Good morning. So 6481 mutation will happen in a subpopulation of patients who are currently on a BTK, yet some part of the population is responding. On the other hand, our emavusertib works on the TLR IRAK4 pathway, so adding EMA to BTK in that population, although may help in some of the patients or the population that has the 6481, but it should augment the BTK inhibition. So the dual inhibition of the TLR and the BCR should inhibit NF-kappa B, which is the driver of the disease, regardless of the presence of a subpopulation that is mutated.
Yeah, and let me add to that as well, Boris. So again, I'm going to take you back to the mechanism of the drug. So on our website in our corporate deck, I think we elucidate this, I hope fairly clearly. The problem of disease for patients with non-Hodgkin's lymphoma, for B-cell lymphoma, is NF-kappa B is in overdrive. What's driving NF-kappa B is the BCR pathway and the TLR pathway separately. BTK inhibitors are blocking the BCR pathway. We block the TLR. Blocking both pathways ought to allow better downregulation of NF-kappa B and better control of this dysregulated process that governs survival and proliferation of cells, of the malignant cells. CYS481 is going to prevent covalent BTK inhibitors from binding at the binding pocket. And that's clearly going to impact the ability to knock down the BCR pathway. By blocking the TLR pathway, again, we're in a completely independent pathway, we should be able to help those patients. For patients with MYD88 mutation, MYD88 mutation typically, as you know, the nidosome complex where MYD88 lives is in the toll-like receptor pathway. When patients have a MYD88 mutation, and the majority of PCNSL patients do, for example, that's going to cause constitutive activation of the toll-like receptor signaling, which, all things being equal, will cause extra overactivity, if that's the right way to think about it, of NF-kappa B. So whether it's a CYS481 mutation or a MYD88 mutation, knocking down toll-like receptor activity ought to be helpful, and that's exactly what emavusertib does. So I think you're right. Those are two key mutations that we would look for. As you know, there are a lot. There are probably 15 to 20 different mutations depending upon the patient and the type of B-cell lymphoma that matter. And we expect to gain more information on that, especially as we add different NHL subtypes into our studies. But at this point in time, I think it's very clear, based on the PCNSL data that we've seen to date, based on the mechanism, preclinical data, and enthusiasm in CLL, emavusertib and knocking down TLR signaling seems to be making a difference. That was a really long explanation. I hope that's helpful.
No, absolutely. That was very helpful. I guess I just had a quick follow-up question. Just in the PR definition of PCNSL, I know you look at brain MRI, eye examination, CSF cytology. Is there any way to kind of report how close these patients were to kind of the threshold of PR, or were they far away from the threshold, so if the FDA reanalyzes, to be confident that they'll come back with a PR as well, versus a patient maybe right on the threshold could be, reclassified potentially as progressive disease?
Yeah, so this is one of the reasons why we went for primary CNS lymphoma, because it is such an aggressive lymphoma. It's part of the DLBCL disease space, right? It's DLBCL that's in the brain. So in these patients, 80% of them are going to come under control with chemo and methotrexate. Once they fail, they're going to go on a BTK inhibitor. Some lower percentage, 40, 70%, depending upon the study you look at, can gain a response. Once they fail BTK inhibitors, they unfortunately progress very quickly. Those are the patients that are coming into our study. So it's not that they're close to PR and they're stable. They're in fact progressing. Their brain tumors are physically growing. And if they do nothing, which is unfortunately what happens to many of these patients, their prognosis is very grim. So there isn't an expectation that some sort of magic will happen. And had they stayed on a BTK inhibitor while their tumors are growing, that it would magically start not just stabilizing, but reduce. That's why it was so powerful. It's why the FDA and EMA were so supportive of us, that we've got a data set that shows clearly when patients who are on a BTK inhibitor have started to progress and their brain tumors are no longer impacted by that BTK and their brain tumors are physically growing, we can do more than stabilize them. We reverse them. That's really unusual. There are no other published data sets I'm aware of in PCNSL where that's ever happened. I think that's why FDA and EMA were excited. It's certainly why we're excited. And I'm hopeful that with our full registrational data set next year, we have the ability to see this have an impact in patients much more broadly as we commercialize. I hope that's helpful.
Great. Thank you for taking my questions. It was very helpful.
Sure.
Thank you. And this concludes our question and answer session. I would now like to turn the conference back over to the company's President and CEO, James Dentzer, for any closing remarks.
Thank you, operator. And thank you, everyone, for joining today's call. And as always, thank you to the patients and families participating in our clinical trials, to our team at Curis for their hard work and commitment, and to our partners at Origin and the investigators and academic community for their ongoing collaboration and support. We look forward to updating you again soon. Operator?
The conference has now concluded. Thank you again for your participation. You may now disconnect.